Hello and welcome. I'm Heather and you're watching Health Mantra with Manipal Hospitals. Now, bone marrow transplant sounds clinical, like a last resort, except it's not, because in the hands of the right doctor, a bone marrow transplant becomes something else entirely. A second chance, a survival story, a medical lifeline. My guest today is the man that brought that lifeline to Goa 5 years ago, performing the state's first ever successful bone marrow transplant. He's a hemato-oncologist and a bone marrow transplant physician at Manipal Hospitals, Goa. And his expertise spans everything from chemo immunotherapy to stem cell rescue and bone marrow failure syndrome. Please welcome Dr. Mahadeva Swamy. Dr. Swamy, thank you so much for joining us here today and welcome.
Thank you.
Dr. Swamy, let's start with a very simple question because most people hear it and immediately think this sounds scary. So what exactly is a bone marrow transplant?
Before we go on discussing on the bone marrow transplant, I would like to put some basics about hematology. Hematology means a condition to deal with the blood and blood forming tissues, basically something related to blood. When we see a blood, we got three types of cells in the blood called red, white and platelet, which has been formed from some tissue called as a bone marrow. What is bone marrow? We have a bone which looks white in color, but inside the bone there's something looks red and yellowish in combination, which we call as a spongy tissue called as a marrow. This produces blood cells, three type of blood cells which we discussed. So if you call three cells as a children, the bone marrow is a mother from where it is produced. For certain conditions, this bone marrow get affected due to certain diseases, cancerous or non-cancerous. When it get affected, we need to change it. What is there inside that? There are some cells which are known for dividing on their own and replenishing the old cells. We call it as a stem cell. In common man language, we can call it as a miracle seed of the blood, called as a bone marrow hematopoietic stem cell inside that red color tissue. So something to deal with changing that system is called as a bone marrow transplant. You change that, so it produces a new set of cells which are much healthier, much stronger, very good immune, replacing the old cells. That forms a brief of about a bone marrow transplant.
But it's not a surgery in the traditional sense. Even you say transplant, we're talking more like a transfusion, because most people hear transplant and they imagine, a big operating table, big risks. Could you clarify that for us?
Yeah. When we hear the word bone marrow transplant, so something that like you are changing the bone, you're doing some, knife involved cutting. No, it's not a surgical procedure. In earlier days where we had a scenarios where once we decide to do a transplant, we put a needle on the bone marrow and take a stem cell from the donor and then transfer it to a patient or a recipient. So there is a minimal surgery involved in that. We need to give anesthesia to the donor and take a healthy stem cells and put to the recipient. But now the technology has been modified where we collect the stem cell from the blood, like how you do a regular donation. But there's a process involved in that, converting the stem cell which are sitting inside the bone to come to the blood which is circulating, leaving the home and coming to the periphery. So we give a certain medications to the donor, make those stem cells
leave the bone
marrow. They mature, they divide, they form a set of cells, they replicate to the 100 times and come out to the peripheral blood. From the peripheral blood, we collect the stem cells and we give it to the recipient. In this process, the surgery is not involved. There is no anesthesia involved. There is no surgery involved. And thanks to the technology, it's called as apheresis. We have a up-to-date apheresis machine where we changed the process of the bone marrow transplant. It's called as leukapheresis.
So basically, it's a replacement of your diseased cells with healthy ones.
Yes, correct.
What are the conditions, doctor, that would require somebody to do that would require a bone marrow transplant?
Transplant, yeah. in a common man, if I want to divide them, indications for the bone marrow transplant, non-cancerous and cancerous. First, I would like to elaborate a bit on a non-cancerous conditions. There are certain set of diseases where the bone marrow doesn't produce a healthy red cells.
Okay.
Most probably inherited diseases. We heard of thalassemia, sickle cell anemia,
Yes.
where the children are dependent on a transfusion. The donor is available and we can change that condition, replace those bad cells with a good one. We can make them a transfusion free. These are conditions, thalassemia and sickle cell anemia.
Okay.
There are other non-cancerous condition called a bone marrow failure, aplastic anemia, where the bone marrow suddenly stops producing any cells,
Okay.
where we take a donor cells and put to them. There are certain inherited immunological disorder, we call it as SCID, basically
Yes.
inherited bone marrow failures, we call it as, where the bone marrow, due to certain genetic condition transferred from the parents, suddenly starts not functioning, where we do a transplant in such cases. Coming to cancerous conditions, there are leukemia, lymphoma, myeloma, where we replace the malignant tissue which is refractory or not responded to the conventional therapy with healthier cells.
Okay, now you said now it's in case of cancerous conditions as well as non-cancerous. Now, I believe there are two types of transplants that you do. You have your autologous and you have your allogenic. Could you tell us in very simple words so our viewers can understand what are these two types of transfers?
Yeah. Autologous, the name itself says that, like taking the stem cells from the own person. In conditions like multiple myeloma and high-grade lymphoma, once we treat the disease, once we put the disease to complete remission, we can collect the stem cell from the same person, from the same patient, store those stem cells, give a strong medicine to empty the older stem cells, that's a bone marrow, and replace them with stored stem cells. It's called an autologous.
Okay.
Very few certain conditions, lymphoma and multiple myeloma. There are certain autoimmune conditions of late medically we are doing, which are not much we are doing in my setting.
Okay.
In allogenic, the second one which you asked for, where we select a donor, most of the times it's a family member.
Okay.
The family member is not available, we get from the registries. So where we take the stem cell from a different person, we call as allogenic. Allo means from other person.
Okay.
So these are the two different transplants.
So one is you take from self, and in the second you take from a donor.
Other person, correct.
Now you said that usually a donor is a sibling, but there are many cases when siblings, either there are no siblings or a sibling is not a match. So you require from an outside donor. Now, what does that process involve? Could you tell our viewers?
So if the match sibling donor is not available, we have two options. One is try to see if there is a half match in the family, either the parent or any other sibling available. We do have something called as haploidentical transplant. If that is not feasible, if the parent is very old or the weight of the recipient, the donor is not matching, where we may not get a good dose of a stem cell, we do something called as matched unrelated donor. We post the information, the HLA is the test which we do, human leukocyte antigen, to know that so and so person is going to match. The donor and recipient is going to match or not going to match. Based on that, if there are 12 points in that, if the 6 points are matching, we call it a half match transplant. If all the 12 points are matching, we call it a full match transplant. We have a registries to quote in our Indian, we have a Datri registry. There are certain registries outside India, DKMS and MDP available, where we send their information to the registries through certain protocols, and they go through their registries and inform us whether the donor available, if the donor available, when and how we are going to get the stem cells from the so-and-so matched unrelated donor.
I know you said that there are registries, but there was a recent news article that NDTV highlighted, where they said that there was this 25-year-old man who had leukemia, and he had to wait for months in order to get a proper donor match. Do you think that there's a severe shortage of stem cell donors in India?
Yeah, problem is the awareness where, where we, like, it's not like a regular donation where you go and donate your blood and okay, it has been stored for many months, you can use. So most of people are not aware about that. So once we increase the awareness, once the registries create more camps and collect the samples, the population registered in the donor will increase and the chance of getting more donor is feasible. Yeah.
But I mean, the government does a lot of drives for, say, blood banking and organ donation. However, for stem cell registration, donor registration, there are no such big drives as such, which is why perhaps the registration is low. Do you think we need to, talk about the fear? Is there a fear factor involved, or is it just mainly awareness as to, I don't know how I would go and donate my stem cells?
Yeah, both things. One is awareness, as you said, other one is fear. There's hardly any harm to the donor, but the donor has to go through certain process. He has to take certain injections to increase his stem cells and then donate. So 1 in million may have some reactions to the injections which we use to the donor. So other than that, there is no any absolute risk for the donor. The awareness is less. I do agree, like, more and more voluntary registration happens, the more chance of getting a donor for each and every one of a patient.
Okay, now you spoke about your autogenic and your allogenic. So your first option, that's option 1. Your allogenic is option 2. There is another option, which is your umbilical cords. Now, I know that, when I was expecting, I was approached by a person asking to store my umbilical cord. And then when I spoke to doctors and other people and I did my own research, I realized that I didn't want to do it because of, whatever reason. But one of that was that umbilical cord, stem cells from an umbilical cord. I mean, the therapies are still experimental. Is that also true today, or have we advanced? Has science advanced?
Umbilical cord, like, is a proven way of doing a bone marrow transplant. Problem here we have is we don't have a registered authority or a registered body to select the pool of the umbilical cords and give certain unique registration number, so that in future we can retrieve where the quality is assured and we are sure that, like, we're going to reuse. So since we don't have a proper registered body, I'm still skeptical to recommend.
What you mean is a national body backed by the government?
Correct, I agree with that. Yeah. So we are skeptical to recommend the individual person to store the umbilical cord where we are not sure how much feasible the same dose which has been stored is useful to the specific person. Because in treatment, we recommend to use at least 4 or 5 units of an umbilical cord to treat one person with whatever bone marrow problem is having. So
one umbilical cord is definitely not enough.
Yes, right.
Okay. Doctor, walk me through the process. So a patient comes in for a bone marrow transplant, day 1. What is it? What do you do?
Okay, good. So in transplant, we do something called as pre-transplant, a transplant period, and a post-transplant. In pre-transplant, we can subdivide as a pre-transplant workup to know that whether the recipient is fit per se. So there are certain issues where we sometimes reject the patient per se, because the patient may be having a terminally cardiac failure, or they may be terminally neurological diseases, or they may be sort of organ failure because liver dysfunction, which we think that, like, not going to reverse, or the transplant treatment is not going to change the outlook. So we contraindicate in such conditions. We need to know the donor fitness. We screen for all sort of whatever possible and do a fitness for the patient per se. And also we look into the fitness of the donor. We screen, do a certain test for the donor. This comes under a pre-transplant evaluation and taking a fitness. Coming to the transplant, we need to prepare the donor. We need to prepare the patient also. Okay. It's like, the farmer he has to sow his seed. You need to remove the weeds, he has to clean it, okay, and then he has to prepare the soil and then sow the seed, something like that. So we prepare the recipient. Recipient preparation, recipient means patient. Preparation is much more than the donor preparation. Okay. So recipient has to go through certain process of a strong chemotherapy to make the recipient's bone marrow empty, so that it accepts the donor. We need to create the space.
Yes.
We need to create the space for the donor cells to come and sit in the recipient, start dividing and growing. Okay. So we need to create a space by doing something called as a conditioning chemotherapy. You have to create a condition, giving a very strong chemotherapy, which puts the immune system of the recipient down. This is a transplant period. Once we, in the side by, we prepare the donor when 3-4 days, 5 days close to the day of a transplant, where we need to collect the stem cell from the donor. We inject certain medication to the donor, as I mentioned, then prepare the donor and then harvest the stem cells from the peripheral blood and then infuse to the recipient. In certain diseases, still we stick to the older method of where we transplant across the generation. If the mother is donating to the son for a certain genetic condition, still we prefer to take a older method of harvesting the bone marrow, anesthesia surgically involved, only few conditions. So once we prepare that, infuse, after infusion we will be monitoring the transplant time, where the immunity is quite low, where there are certain measures to prevent the infection of the recipient. Because the immunity is quite low, we put them in isolation and we put them on certain cover to prevent the infections, the viral infections or bacterial infections. This is called as transplant period. And we monitor for the growth of the cells which are put. We need to monitor to know that whether the cells which are infused are going to grow and divide and form a new family of red cell and white cell platelets. Generally it takes 15 days to 20 days for the recovery as a transplant. And there is something called as a post-transplant period, which we'll discuss further.
So I think what you're trying to say is that although it's a controlled step-by-step process, even though the immunity of the recipient, which is the patient, is low, you manage to, the patient needs to be isolated and kept away from all kinds of infection. Is that correct?
Correct, yeah. So isolation is the right word, where we have a specific rooms for that, HEPA filter room we call it as, where the food and the water which comes is sort of sterilized, where everything we need to keep a contamination to the zero. The bacterial load should be as low as possible under cover of certain prophylaxis of medications.
Yeah. Until the patient's immunity builds?
Yeah, 15 days to 1 month. Period.
Okay. Yeah. Now, Dr. Swamy, you said that, before you prepare a patient for transplant, you spoke about giving the patient chemotherapy to kill the existing disease stem cells. However, in most cancers, chemotherapy is usually the frontline treatment. Now, how do you decide that, we need to do a bone marrow transplant for patient A rather than just continuing with chemotherapy?
Yes. So once we diagnose the disease, cancerous, at the time of diagnosis, we risk stratify whether this person in future is going to work with a chemotherapy, immunotherapy, or whether this person is going to require a transplant. We keep in mind something called as after the diagnosis. We heard of diagnosis, but we should also be aware that risk stratification, something like a staging of a cancer we call it as, but in hemato-oncology we call it as a risk stratification, to know that whether this said disease has got a high risk disease where the conventional chemoimmunotherapy may not work, where we may in future go for a bone marrow transplant. Okay. That's one set. After the diagnosis, we do a treatment, so chemotherapy, immunotherapy. After the treatment, we need to assess the disease, called as a disease reassessment. We use a certain set of tests which has been done on the baseline at some interim period to know that the person is responding. In leukemia, we do a repeated bone marrow test which has been done on the day 1, compare them the day 1 and the end of the induction therapy or whatever said therapy, to know that whether the residual disease is in terms of a 0. Okay. One thing. Second thing, for lymphomas, we do something called as a PET scan to know that the load of the disease has come to the said score. If we feel that this has been refracted to the said conventional chemo or immunotherapy, we declare them as a high-risk disease or a refractory disease, and then we change the line of the therapy and we prepare them for the transplant. So transplant is not suddenly decided. It's through a process. We try certain measures and then we take on a transplant decision.
Is every patient eligible for this transplant? Are there age or health-related restrictions involved?
Okay, so age is a factor which is mentioned. Rather than age, we say as fitness of a recipient, or age of a donor. So generally above 60 years, certain centers above 65 years, provided there are no any terminal illness or unfit patients, generally we say that below 60 or below 65 years is the age of recommendation. As I mentioned in previous points, that there are certain irreversible conditions of a recipient where we say that transplant is not going to change the outlook of a disease. Other than that, if everything is fine and below 60 years, we consider for a transplant.
Doctor, now we've been talking about your bone marrow transplant. Bone marrow transplant has been around since the 1960s, but in Goa, it happened just 5 years ago. And let's talk about that historic moment. I mean, you were one of the first you were the first doctor to lead a team that conducted a successful bone marrow transplant in Goa. It must have been huge. Can you tell us, can you tell our viewers a bit about that?
Yeah, it was bit of mixed emotions, stress and success both involved. Where he was in age group of around 52 year, he had got an high risk disease where he tried a conventional chemotherapy where we assessed the disease. There was a residual disease, so we changed the line of the therapy and consult the family. The family was sort of it took a time, it took a lot of counseling process involved. They has to mobilize the funds. There were little financial constraints, but finally we arranged. It was quite a sort of baby steps for us. We trained the nurses and the doctors who are everything's new for them.
Okay.
Thanks to my teachers, where I learned from them, where they gave us the courage to start as a one-man show. In just a short notice of 1 month, we were able to arrange, and then the family cooperated, the hospital team gathered, and then it was a sort of a journey where everything got hand in hand, and the till date it's almost a 5 year. The patient is doing well.
I think that's, I mean, a huge, not just personally, but for the state's entire healthcare system. So let's talk, a bit about myths. Now, there are a lot of myths surrounding bone marrow transplant, a lot of fears that patients have. One of which is that if a transplant fails, there is nothing more that can be done. Is this true?
Yeah. As we discussed, we are going to little sort of higher concept, like if the transplant fails, we do a second transplant. But we need to counsel the outcome, and we need to look into the condition of the recipient, how fit. So there are upcoming cellular therapies where we use a certain cells without doing a proper transplant. We collect the certain cells. We heard of something called as CAR-T. We need to discuss in coming sessions. There are cellular therapies available. There are certain ways to address the transplant failure. One is a second transplant, other one is a cellular therapies.
One last question.
Change the donor is another thing which I need to mention here. Like if that donor is not working, you get an alternate donor.
Oh, so maybe it was the donor cells that didn't agree with you.
The body rejects because it's once we put a cells, as I said, like, we are changing the blood, we are not changing the entire system. Once they go in, either the recipient will mount a response, though we created the space and prepared the recipient, but still there can be a chance that the recipient can reject the
immune response
of the residual immune response of the recipient, or that donor cells sometimes show too much of action, that we call it as a GVH.
Okay.
So in these conditions where we think that, like, where the recipient rejects the donor, we think of a second transplant, an alternate donor.
There's another fear. Now, this we spoke about the patient. There's another one from the donor side. Donors fear. I mean, perhaps that's why we have a low stem registration donor rate. Donors fear that if they donate stem cells, they're prone to infections. They become weak. They're prone to more infections. And could you address this for our viewers, please?
Per se donor process, there's no any risk of increasing the infections. They feel a bit of weakness for 1 or 2 days, which is hardly anything, makes any difference to the day-to-day activities. I don't think anything, just we need to reassure, get a proper counseling done for the donor, looks a better solution rather than creating myth or fear,
Okay, one last question, doctor. For someone who's been told that they need a bone marrow transplant, is there anything that you would want to say to them?
So if someone needs a bone marrow transplant, there is a fear involved. What is my success? How much risk involved? So we'll have a detailed counseling sessions. The patient and the family needs a counseling where we say that, like, where nothing can address or cure the disease, there is a light at the end of the tunnel. Do something rather than keeping surrendering to the disease, and you can win the race and fly with a cure or a colors.
So I think, even though a bone marrow transplant might sound scary, as doctor said, there is always light at the end of the tunnel. So don't be scared. Help exists, support exists. There is always a path forward. Now, Dr. Mahadeva Swamy is a top-tier hemato-oncologist here at Manipal Hospitals, Goa, with strong credentials, a proven track record. If you would like to consult him, he is available Monday through Saturday, 9 a.m. to 5 p.m. at Manipal Hospitals in Donapaula, Goa. Dr. Mahadeva Swamy, thank you so much for your time and for your insights.
Thank you. Namaste.
And to you, our viewers, thank you for tuning in. This is Health Mantra. I'm Heather. I'll see you again soon right here on Prudent Media.